Hypertension in children and adolescents. Hypertension in children is defined as an average systolic or diastolic blood pressure that is greater than or equal to the 95th percentile for gender, age, and height on 3 or more separate occasions taken in the right arm in view of possibility of coarctation of the aorta. Appropriate cuff size that covers 2/3 of the length of the arm between the shoulder and the elbow and encircling the whole arm should be used. In general, a blood pressure of greater than 110/70 millimeters mercury in children aged 2 to 5 years and more than 115/76 millimeters mercury in those aged 6 to 12 years and more than 128/82 millimeters mercury in adolescents is considered abnormal and would require a referral to a pediatrician or an evaluation by a pediatrician. Most adolescents and childhood hypertension, especially in infants and younger children, is due to secondary causes. Adolescents, however, may have early onset of primary hypertension. Causes are renal, for example, chronic pyelonephritis, hydronephrosis. It could be vascular, that's, for example, coarctation of the aorta, renal artery stenosis. It could be endocrine, like pheochromocytoma, Cushing's syndrome, adrenal disorders. Also, obesity could be a cause, and primary hypertension too. The symptoms are chest pain, headaches, dyspnea on exertion, excessive sweating, leg swelling, palpitations, hematuria, and unconsciousness, as in hypertensive encephalopathy. The signs that are usually elicited include BP greater than 110/70 millimeters mercury in children aged 2 to 5 years, and also BP greater than 115/76 millimeters mercury in children aged 6 to 12 years, and also more than 128/82 millimeters mercury in adolescents. So signs pointing to a specific cause for secondary hypertension could be present. Investigations the same as that of adults, and this includes FBC, urinalysis, blood urea electrolyte creatinine, blood glucose, serum lipids, serum uric acid, chest x-ray, 12-lead ECG, ultrasound scan for of kidneys and adrenals, and it is suspected secondary hypertension, also echocardiogram. Okay. And constant BP monitoring. The main treatment objectives are to reduce blood pressure to a target of less than 95th percentile for age, gender, and height in the absence of end organ damage, to less than 90th percentile if end organ damage is present, and also to prevent complications, to manage underlying secondary cause, to encourage weight reduction in obese and overweight children. Non-pharmacological treatment, therapeutic lifestyle changes, weight control, regular exercise, low fat intake, low sodium diet, regular fruit and vegetable intake. Pharmacological treatment, can give angiotensin converting enzyme inhibitors, as ACE inhibitors. Um, give Lanapro oral in children 12 to 18 years. Initially, you give 2.5 milligrams daily, and it's increased to a maximum dosage of 10 to 20 milligrams daily in 1 to 2 divided doses, and 1 month to 12 years. Initially 100 micrograms per kilogram daily, which is increased to a maximum dosage of 1 milligram per kilogram daily in 1 to 2 divided doses. And in neonates, 10 micrograms per kilogram daily, which is increased to maximum dosage of 500 micrograms per kilogram daily in 1 to 3 divided doses. For diuretics, you give bendroflumetazide oral in children 12 to 18 years. You give 2.5 milligrams daily. 2 to 12 years, you give 50 to 100 micrograms per kilogram daily. And 1 month to 2 years, you give 50 to 100 micrograms per kilogram daily. For beta blockers, you give propranolol oral in children 12 to 18 years. You give 80 to 160 milligrams 12 hourly. And 1 month to 12 years, give 250 micrograms to 1 milligram per kilogram 8 hourly. And in neonates, you give 250 micrograms per kilogram 8 hourly. Or you can give atenolol oral in children 0.5 to 1 milligram per kilogram daily, with a maximum dosage of 2 milligrams per kilogram daily. You can give calcium channel blockers, for example, nifedipine oral in children 12 to 18 years. You give 5 to 20 milligrams 8 hourly, and from 1 month to 12 years, you give 200 to 300 micrograms per kilogram 8 hourly, the maximum dosage of 100 milligrams daily. Or you can give amlodipine oral in children 12 to 18 years. You give 5 to 10 milligrams daily, and 1 month to 12 years, you give 100 to 400 micrograms per kilogram daily, with a maximum dosage of 10 milligrams daily. You can give vasodilators. So for hydralazine oral in children, you give 25 milligrams 12 hourly, which is increased to usual maximum dosage of 50 to 100 milligrams 12 hourly, as in children 12 to 18 years. So 1 month to 12 years, you give 250 to 500 micrograms per kilogram 8 to 12 hourly, which is increased to the necessary limits, or increased as necessary to a maximum dosage of 7.5 milligrams per kilogram daily, not exceeding 200 milligrams. For neonates, you give 250 to 500 micrograms per kilogram 8 to 12 hourly. It is increased as necessary to a maximum dosage of 2 to 3 milligrams per kilogram 8 hourly, as every 8 hours. And can give IV, that's 250 to 500 micrograms per kilogram diluted in 10 milliliters normal saline, is given over 20 minutes, and then 100 to 200 micrograms per kilogram 4 to 6 hourly, the maximum dosage of 3 milligrams per kilogram in 24 hours. For angiotensin receptor blockers, give losartan oral in children. The initial dose is 0.7 milligrams per kilogram daily, with a maximum dosage of 50 milligrams, and a maintenance dose of 1.4 milligrams per kilogram daily, with a maximum dosage of 100 milligrams. Referral criteria: to refer all cases of hypertension in children to a specialist for investigation and further treatment.